Hello everyone, my name is John Lowe. I'm a PGY4 emergency medicine resident at the OSU Medical Center program. Today we will be discussing shock states and resuscitation. I have no disclosures to report. We will discuss a little bit about the epidemiology and pathophysiology of shock. We'll discuss some of the categories of shock. We'll go over some treatments of shock. We'll discuss some ACLS algorithms, and then we'll go over some common cardiac dysrhythmias and an approach to dysrhythmia evaluation. So, starting off, epidemiology of shock. It's difficult to assess the exact number of cases seen nationwide. Previous estimates propose that there's more than 1 million cases of shock seen in the emergency departments across the country each year. If you define shock by a systolic blood pressure of less than 90, there would be about 5.6 million cases of shock in the emergency department each year. Mortality, septic shock is around 50%. Approximately 40% of that die within 1 month of presentation of initial septic shock. And then cardiogenic shock is again approximately 45%, with 75% of those dying within the first month of their presentation. Pathophysiology. Shock is a state of circulatory insufficiency that creates an imbalance between tissue oxygen supply and oxygen demand, resulting in end organ dysfunction. Again, not enough oxygen to the tissues is basically what shock is not enough oxygen and perfusion to the tissues to allow for aerobic respiration at the cellular level, and leading to a buildup of cellular waste and lactic acid and anaerobic metabolism. So oxygen-containing fluid, as far as a model for shock, is moved through pipes, which are your vessels, via the heart, which is a pump, to tissues. Shock can occur as a result of an insult to any of these components. So this is kind of one way to look at different shock states. Is there is blood going through vessels from the heart, or you can look at it as fluid moving through pipes via a pump. So the four broad categories of shock are hypovolemic, cardiogenic, distributive, and obstructive. So again, hypovolemic, there's a problem with the fluid, not enough fluid in the pipes to go round and round. Cardiogenic, there is a problem with the pump. The pump is not able to push the fluid round and round. Distributive shock, there's a problem with the pipes are leaking. And then obstructive, there is a problem with fluid getting out of the pump. Something is blocking it. Physiologic considerations, a couple of things to remember. Your cardiac output is the measure of your stroke volume times your heart rate. It is dependent on your preload, your afterload, and your contractility as far as your stroke volume goes. Your mean arterial pressure then is equal to your cardiac output times the systemic vascular resistance. So if you take all of that combined, your mean arterial pressure is equal to your stroke volume times your heart rate times your systemic vascular resistance. And expanding on that even further, your map then is dependent on your preload times your afterload times your contractility times your heart rate times your systemic vascular resistance. So there's multiple areas that affect how well you perfuse your body. Map of 60 to 65 is necessary to maintain adequate perfusion to your end organs. Factors that affect your cardiac output: adrenergic tone increases in shock states, leading to an increased inotropy, increasing the strength of the heart contraction; an increased chronotropy, which is an increase in your heart rate. It also increases your lusitropy, which is the ability of the heart to fill, and then an increase in your systemic vascular resistance, except in distributive shock. Lactic acid, again, low flow, low oxygen delivery states, or failure of oxygen to get delivered to the cellular level, leads to anaerobic metabolism and the formation of lactic acid and other cellular waste products, ultimately leading to cell death. Acidotic states can contribute to weakened ventricular contraction and lead to further decreases in your blood pressure, further worsening your anaerobic metabolism and lactic acid formation, worsening the acidosis, and leading into a vicious cycle. Compensatory mechanisms of shock leads to a cascade of events that attempt to correct this oxygen delivery. You can see here carotid baroreceptors get activated, triggering sympathetic responses. You get arterial vasoconstriction that redistributes blood from the skin, muscle, kidneys, and splanchnic viscera to the more critical organs, the heart, lungs, and brain. Heart rate increases and contractility increases, leading to an attempt in increasing your cardiac output. Your venous system attempts to constrict, leading to an increased venous return. You get vasoactive hormones released, leading to increased arteriolar and venous tone. You also get antidiuretic hormone and activation of the renin, angiotensin aldosterone system to try to maintain your intravascular volume. Again, failure of these compensatory mechanisms, so redistribution of blood to the heart and brain, compromises kidneys, your GI tract, and other critical organs. As that continues, you get failure of oxygen delivery, leads to cellular ion pump dysfunction. You get influxes of sodium, effluxes of potassium, resulting in resting membrane potential differences. This progression of shock leads to cellular death, leading to hyperkalemia, hyponatremia, azotemia. You can sometimes get hyper or hypoglycemia and lactic acidosis. So we'll talk a little bit about the SIRS criteria. This is what used to be kind of the gold standard for identifying concern for sepsis. Early shock may lead to two of the following for SIRS criteria. So a temperature greater than 100.4 or less than 96.8, heart rate greater than 90, respiratory rate greater than 20, or a white blood cell count greater than 12 or less than 4. Problem with that is it's kind of nonspecific, and a lot of pathologies can cause any of these without being infectious. If I was to run up the hill outside OSU Medical Center, I would have a heart rate greater than 90, a respiratory rate greater than 20, but that doesn't mean that I have sepsis. End results of shock end up being multi-organ dysfunction syndrome. It leads to renal failure. You end up with liver failure, DIC, respiratory failure, end up getting myocardial depression, and eventually cardiac arrest. You can kind of see there on that picture that you'll get a lot of different outcomes from it. So you'll get oliguria in the renal system, leading to acute kidney injury or acute renal failure due to increase in creatinines and BUNs. Your cardiovascular system, you can get tachycardic. You can end up getting heart failure out of it, and eventually cardiac arrest. You can start getting DIC, petechial formation on the skin. You get hypoxia and tachypnea. You get liver failure, all the things that end up going badly for patients who are in prolonged shock states. So, again, hypovolemic shock is not enough fluid. So you have decreased intravascular fluid or blood volume. The hemodynamic changes associated with this, you have a decreased preload, decreased stroke volume, and decreased cardiac output. Etiologies, GI losses, burns, capillary leaks, hemorrhage. Those are some of the big ways that we can end up in hypovolemic shock. Cardiogenic shock, that's your broken pump. Left ventricle fails to deliver oxygenated blood to peripheral tissues. Hemodynamic changes seen in this is typically they have an increased preload, associated with an increased afterload, an increased systemic vascular resistance, and a decreased cardiac output. So etiologies of this, most commonly seen in myocardial infarction, sometimes in arrhythmias, and commonly in patients with valvular disease, and also those with known heart failure. Obstructive shock, that's a problem with getting fluid in or out of the pump. That's a decrease in venous return or cardiac compliance due to increased left ventricular outflow obstruction or marked preload decrease. So hemodynamic changes seen on those is decreased preload, increased systemic vascular resistance, and a decreased cardiac output. Common etiologies of this is going to be your tension pneumothorax, your cardiac tamponade, or pulmonary embolism. And then there's distributive shock, and these are the constellation of different shock states that cause your big leaky pipe. So that's sepsis or anaphylaxis or neurogenic and adrenal insufficiency. But these, it is caused by intravascular volume depletion due to marked systemic vasodilation. You just don't have enough systemic vascular resistance. So you'll get decreased SVR, you'll get a decreased preload, increased heart rate, and it has kind of a mixed effect on your cardiac output. So this is a table out of Tintinelli's that has just kind of a composite finding of physical exam findings that you'll see in shock states. So it's good to look over and kind of see. These are things that you can find on your physical exam that might help you guide you as far as determining what type of shock you're dealing with. So diagnosis of shock, obviously history and physical exam are going to be two of your most important findings, but then there's multiple different things you can do to help diagnose the underlying cause. So laboratory evaluation is important, CBC, CMP, plus minus magnesium and calcium and phosphate for cardiac concerns. Lactic acid rise correlates with mortality. Clearance with repeated draws correlates with improved outcomes. You want to do coagulation studies, EKG, urinalysis. Books talk about arterial blood gases. The majority of the time in the emergency department, a venous blood gas is perfectly adequate because it correlates well with what is necessary information to help guide shock therapy. ABGs are painful to the patients and usually unnecessary, so usually a VBG is adequate for all but the very rare case where an ABG may be indicated. Cultures, blood, urine, wounds, searching for sources of infection. If you suspect a primary adrenal insufficiency or an issue along those, a cortisol level may be indicated. Obviously, pregnancy testing is important. You want to rule out ectopic hemorrhage as ectopic pregnancy leading to hemorrhaging as a cause. Imaging studies, X-ray, ultrasound. Ultrasound is incredibly helpful in differential diagnosis. There are several different protocols to be used. The most common one we're using now is the Rush exam. It is used to evaluate multiple different areas for undifferentiated hypotension. It's called the rapid ultrasound for shock and hypotension, and looks at your basically is a fast exam with a bedside echo, as well as evaluating your lung slide for pneumothorax and evaluating your vena cava and aorta. So lots of different things you can do to gather a lot of information very quickly on your bedside exam and testing. And then CT as history and physical exam dictate. So you can do a CT chest, CT abdomen, CT head, CT angiography studies if you're concerned for dissection or pulmonary embolism. That's just going to be led by your history and physical exam findings. Early treatment, establishing airway. Depending on the patient's mental status and disease severity, intubation can be required, but it can also worsen cardiac output as it affects your intrathoracic pressures and your preload. Volume resuscitation and vasoactive agents should be initiated beforehand if possible. Controlling the patient's work of breathing. This is where intubation early in severe sepsis may be beneficial. You can actually breathe for the patient, which takes away a significant amount of the metabolic work of the respiratory muscles, which allows that blood to be shunted to other places, decreasing metabolic demands across the board and increasing oxygen delivery to all aspects of the body. So, optimizing circulation principles, again, in emergency medicine. If you're doing an acute resuscitation, 2 large bore IVs, 18 gauge or larger, if possible, are important. Appropriate fluid resuscitation is going to be important. That you can see there at the top. Trendelenburging a patient does not help with circulation. It may help you get an IV in an EJ or something if necessary, but it's not going to help as far as long-term benefits. You can lift the patient's leg, do a straight leg raise, and then recheck a blood pressure. If the patient's blood pressure increases significantly, 20 millimeters of mercury on a systolic side, they're probably fluid down and can tolerate a little bit of a fluid bolus. Fluids, isotonic crystalloids, for example, normal saline or lactated ringers, you want to give them in 500 ml to 1 liter boluses, as long as they're not acutely volume overloaded. It's common for patients with septic shock to require a large amount of fluids in the first 24 hours, some up to about 6 liters. There's studies out there comparing normal saline to lactated ringers. No significant difference in outcomes. Lactated ringers does have fewer renal issues. So if you're going to be doing large volume resuscitation, you may consider lactated ringers, but you're not wrong to do normal saline either. They both work just as well. So the goal is get some type of isotonic crystalloid on board and help improve their perfusion pressure. Pressors, initiate if inadequate response to fluids. Keep your MAP around 65. Levophed or norepinephrine is your first line. Second line is not well defined. In the Surviving Sepsis campaign, it was maybe dopamine. It kind of depends. Typically, it will also depend on the type of shock that you're dealing with. If it's cardiogenic, then your second line will most likely be dobutamine. If it's septic or anaphylactic, then epinephrine. In severe acidosis, vasopressin actually acts through a different mechanism than the catecholamines, so that way it gets less affected by acidosis. So vasopressin effects may be preserved while the efficacy of some of the others may wane a little bit. Again, early treatment, ensure oxygen delivery. You want to make sure that they're not hyperadrenergic and shivering because you don't want to increase oxygen consumption. You want to do adequate pain control because pain suppresses myocardial function, which will lead to decreased oxygen delivery. So pain relief, muscle relaxation, keeping the patients warm, give them anxiolytics is needed. And then, like we talked about, sometimes even intubating and paralyzing these patients to decrease metabolic demands will increase decrease their morbidity and mortality. You want to transfuse packed red blood cells to maintain a hemoglobin above 7. You want to make sure there's enough boxcars in the blood carrying oxygen. Endpoints of resuscitation. Non-invasive measures are poor indicators of adequate resuscitation. So heart rate, blood pressure, urine output underestimates the degree of hypoperfusion. There are some controversies out there in the literature, but generally shoot for somewhere around a MAP of 65. The literature says keep a CVP of somewhere between 8 to 12. We don't do that in the emergency department. That requires floating, Swan-Ganz, and some other things. They also talk about a central venous O2 sat of greater than 70%. Again, not in the emergency department. And then keeping your urine output at greater than 0.5 ml per kilogram per hour kind of helps guide your therapy a little bit. So really for us, we look at other things in the we want to make sure improving mental status if the patient's not intubated. Is their MAP good? Is their urine output good? Do they show signs of improved perfusion? Is their capillary refill improving? Things like that. Source control is always important, so infection, hemorrhage, etc. Whatever you need to do to stop whatever is causing the underlying cause of their shock state needs to be done. So we talked a little bit about this. Fluid choice, colloids versus crystalloids. Less volume required on your colloid therapy. Crystalloids, 2 to 4 times greater volume required. So an example of a colloid would be something like albumin versus lactated ringers. There's no outcome advantage. There is a cost advantage to crystalloids as they are significantly cheaper than any of the colloids. Bicarb is another one that's a controversy of treatment. It's supposed to shift the oxygen hemoglobin curve to the left, meaning less oxygen is unloaded at the tissue level. However, acidosis can worsen cardiac output. So you got to kind of balance this. If you're profoundly acidotic and having decreased contractility or development of an arrhythmia, maybe giving some bicarb to protect from that output to increase your cardiac output may help offset the oxygen hemoglobin curve shifting, but it's not really, it's rarely indicated to give bicarb boluses. All right, talk about ACLS. About 7 to 8.5 million people per year suffer some form of cardiac arrest. Approximately 70% of them are out of hospital, and 80% will have some type of ventricular tachyarrhythmia. VFib will rapidly progress to asystole in about 15 minutes. Without some type of defibrillation, survival decreases by about 10% per minute. If greater than 12 minutes in ventricular fibrillation, there's a less than 5% chance of survival. So this is coming from ACLS, this idea of chain of survival. So early access, early CPR, early defibrillation, and early advanced care. So the goal is to have less than 5 minutes for first shock. This increases the rate of survival to almost 20%. Primary survey in a cardiac arrest or ACLS is identification of the arrest. So you need to know critical rhythms, VFib, pulseless VTAC, asystole, and PEA. Again, high quality CPR in a patient who does not have a advanced airway. It is 30 compressions for every 2 ventilations. You want to be compressing at a rate of 100 to 120 beats per minute for at least 2 inches into the chest, or 1/3 of the anterior posterior diameter of the chest. Defibrillation, mechanical or automated. Many places in the communities all now have AEDs available. So the idea is to get them onto a patient and see if they will be a candidate for defibrillation early, immediately resuming compressions following the shock, breathing and pulse, and then ROSC management. If not, then secondary survey. Secondary survey, this is where you're going. So securing the airway, that's either endotracheal intubation or some sort of supraglottic airway. Breathing, you want to ventilate with your bag valve mask, making sure that they have adequate oxygenation, and then eventually transitioning them to mechanical ventilation. Maintaining circulation, again, high quality CPR is what saves lives, so you want to make sure you're doing high quality CPR and doing the best you can to get to early defibrillation or cardioversion. Continuous ECG monitoring, is important so you can identify rhythms and rhythm changes and treat appropriately. You want to establish 2 large bore IVs. If you can't get an IV, then quickly obtain an IO, and then follow the ACLS algorithms for medication management. There are some studies coming out about ECMO-assisted CPR. There are no places in Oklahoma that are doing that, but there's some in Minnesota and a few other places that are looking at rapidly initiating ECMO on patients who have out-of-hospital cardiac arrest within a certain time period whose presenting rhythm was AFib or I'm sorry, not AFib, VFib or VTAC. And they're showing good outcomes from that, but it's not broadly accepted yet. And then running through your differential diagnosis. So why is the patient not responding to resuscitative efforts? This is where you'll hear in ACLS algorithms for, say, a PEA, what is their underlying rhythm? Is it PEA? You have to run your H's and T's, your reversible causes of pulseless electrical activity. Same thing for non-responsive VTAC and VFib. Is there an underlying cause that needs to be treated? Some of the drugs we use in ACLS, obviously, crash cart epinephrine. It is a 1 to 10,000, usually given as 1 milligram IV, and it's given every 3 to 5 minutes. It can be used in all ACLS rhythms: pulseless VTAC, VFib, unresponsive to defibrillation, asystole, PEA, and symptomatic bradycardia. So it's an endogenous catecholamine. It increases peripheral vasoconstriction, which hopefully helps perfuse the brain and heart better. Most common reaction is tachycardia, which can worsen myocardial ischemia, induce some type of ectopy and ventricular tachycardia. But when used appropriately, it can help with reestablishing ROSC. Amiodarone was another one that is discussed. It is a class 3 antiarrhythmic. It is used in persistent VTAC and VFib, post-defibrillation and epi. The dose for pulseless VTAC and VFib is 300 milligrams IV, followed by saline and dextrose in water. You may do an additional 150 milligrams if no response. For stable ventricular dysrhythmias or SVT, you can give 150 milligrams over 10 to 15 minutes, followed by an infusion at 1 milligram per minute for 6 hours and half a milligram per minute for 18 hours. Lidocaine was taken out of the ACLS algorithms. I believe it was recently put back in. It is a second-line choice. It's a class 1 antiarrhythmic. Amiodarone is still preferred. The dose is 1 to 1.5 milligram per kilogram. It is toxic over 3 milligrams per kilogram bolus, or if the patient has liver disease. Magnesium, cofactor for numerous reactions. This is used to treat suspected cardiac arrest from some type of QTC prolongation, including torsades. You give 1 to 2 grams and 10 mLs of dextrose in water over 1 minute. It can cause flushing, sweating, and asystole with rapid administration, so you want to make sure that you don't give it too fast. So in deficiency, you get cardiac arrhythmias, sudden death, precipitation of ventricular fibrillation. If you give too much hypermagnesemia, that's where you get flaccid paralysis, respiratory depression, and depressed reflexes. So knowing what you're looking for to make sure you don't overdose your patient on a magnesium, but it is indicated in patients who have torsades or suspected cardiac arrest from QTC prolongation. Atropine, it's a parasympatholytic targeting the SA and AV nodes, not to be used in PEA or cardiac arrest. It is used for symptomatic bradycardia. The dose is 0.5 or 0.6 milligrams IV. It recently, in the last iteration, just went to 1 milligram IV. I'm not sure what the test will reflect for you guys if you get a question on atropine, but know that it was 0.5 milligrams IV. It has now gone to 1 milligram IV. for symptomatic bradycardia times 3 doses for a max of 3. Calcium. This is given only for cardiac arrest from hyperkalemia or hypocalcemia or from a calcium channel blocker overdose. Large amounts are needed for calcium channel blocker overdoses and for hyperkalemia. Typically, it's important to know that the ratio between, there's 2 types of IV calcium chloride and calcium gluconate. Calcium chloride is generally given through a central line and calcium gluconate generally given through peripheral IV. However, calcium chloride is 2 to 3 times more potent. So if you're going to give equivalents, you need to be giving 3 grams of calcium gluconate or 3 amps of calcium gluconate for every 1 of calcium chloride that you're giving. Sodium bicarb, no longer recommended for routine use. It is indicated in cardiac arrest from hyperkalemia or tricyclic antidepressants. Vasopressin, it is stored in the pituitary, increases water absorption and peripheral vascular resistance. In laboratory studies, it shows supposed to be better than epinephrine. However, it's not clinically played out that way and does not have is not recommended for clinical use over epinephrine. So we'll talk about some common algorithms here. VFib and pulses VTAC. First and foremost, high quality CPR and defibrillation. If it's persistent, again, 2 minutes CPR, high quality rhythm analysis, and repeat defibrillation. Defib is 150 to 360 biphasic. Typically, you'll stop at 200 on a biphasic. If you have a monophasic machine, it's 360 joules. Begin secondary survey. That's when you start doing your drugs every 3 to 5 minutes. PEA asystole. That's CPR and epinephrine. And then you start ruling out your other causes of arrest, your reversible causes. So narrow complex PEA, do they have some type of cardiac tamponade, pneumothorax, pulmonary embolism? If they have a wide complex PEA, are they metabolic toxicity? Do they have some type of drug toxicity? Are they in cardiac ischemia? Do they have hyperkalemia? You start treating and addressing the H's and T's, which are now posted here. So you want to make sure that you're checking all of these things when a patient presents in PEA or asystole. Post-ROSC complications. For those of you who don't know what ROSC is, that's return of spontaneous circulation. But some of the complications from that is reperfusion injury. So hyperoxia harms postsynaptic neurons. So you want to make sure that you're not over-oxygenating these patients. These patients need to be kept on their pulse ox waveforms. They need to be somewhere between 94 to 98. You don't want them sitting at over 100 because you can actually cause worsening outcomes. They can have anoxic brain injuries depending on how long they were down for without perfusing their brain. And then there's post-cardiac arrest myocardial dysfunction. You can decrease complications by routine EKG monitoring. You want to maintain a higher MAP than baseline, 65 to 100. Performing an echocardiogram. There was targeted temperature management used to be kind of the gold standard, but it's going away. There's been a couple of studies that show that hypothermia does not necessarily increase or improve outcomes, but prevention of fever does. So maintenance of normothermia is more important than hypothermia. Glycemic control, tight glycemic control. You don't want them to be hypo or significantly hyperglycemic, and then frequent neurologic assessments. ECMO is a good bridge therapy until definitive treatments. So there's 3 different types. There's veno-arterial, which would be useful in cardiac arrest. It's the IVC to the aortic arch or femoral artery. Veno-venous, which is respiratory failure, and then arteriovenous. And those are only for patients who require gas exchange. Now we'll talk about some common cardiac dysrhythmias. So we'll start here with the tachycardic dysrhythmias. So you want to look at 5 steps. IV, O2, monitor, advanced airway, and defibrillation. Available in the rooms. You want to make sure, assess, are they stable or unstable? So let's start that again. I'm sorry. 5 steps are, you want to make sure you have your safety net. Assess, is the patient stable or unstable? It's not dichotomous. They can be stable at one moment and unstable at the next. Evaluate for P waves. Determine if it is regular or irregular, and is it wide or narrow. For arrhythmia groups, so you have narrow regular, narrow irregular, wide regular, and wide irregular. So we'll start here with narrow complex regular tachycardia. That's going to have a QRS less than 0.12 seconds. This means that it is traveling through the AV node, and the treatment of this is to block the AV node. These are some of your examples of your narrow complex regular tachydysrhythmias. So you've got paroxysmal supraventricular tachycardia, a flutter with a consistent block, orthodromic WPW, or narrow complex VTach. So again, here's SVT coming from the sinus node to the AV node, and then it ends up circling around in the AV node and firing repeatedly. Orthodromic WPW, obviously it's following the generalized pathway, but then it comes back up through the accessory bundle and then runs back in down the AV node. A flutter and AV nodal blocks. It's atrial flutter. Basically the atria are fluttering, but the AV node is blocking some of those conductions down, so you're getting narrow complex regular appearance even though you're still in a flutter. Here's an example of that. So you can see that you're getting a fixed flutter, 2 flutter waves for every QRS complex. Narrow complex regular treatment, you want to do some type of AV nodal blocker. Typically we'll start with adenosine, 6 to 12 milligrams. Typically in the emergency department, the book says start with 6 and then go to 12, but typically in the emergency department for an adult, we will start with 12 because it can be significantly uncomfortable, and this can cause the patient may not allow you to try a second time, so we usually go with the larger dose first. If that fails, then you can do another AV nodal blocker such as diltiazem or one of the beta blockers. If they are unstable, then it's cardioversion. Atrial flutter is not treated but diagnosed. Again, that's a long-acting AV nodal blocker. Adenosine, just knowing that there's some drugs that it can potentiate and inhibit or are inhibited by it, so just making sure that you're addressing these types of things. Heart transplants, central line, those things can potentiate adenosine. Caffeine and theophylline are inhibitors, and adenosine is contraindicated in acute asthma exacerbations. If they're not an acute, if they are an asthmatic and not an acute exacerbation, then it's okay to use. So here's our number 2 category for tachydysrhythmias, your narrow complex irregular. So these are going to typically be 3 common ones, and that's going to be your atrial fibrillation. It's going to be a flutter with variable block or multifocal atrial tachycardia. So irregular, not VTach, not sensitive to adenosine because it's not a circus movement, meaning it's not running, just sitting there going in circuit around and around. It's due to increased automaticity. So this picture is demonstrating, again, atrial fibrillation. So the atrial firing from all over the place, sending impulses down to the AV node. They're hitting the AV node, and they're getting transmitted down the His-Purkinje system at random intervals in a tachycardic response. So that's going to give you that irregular appearance to the EKG. You'll get beat, off a beat, and it's just going to kind of tack along there in an irregular rhythm. Again, here's another example of that. There's no real regularity to the EKG. It kind of spaces itself out. There's a couple of beats that may appear regular, then there's some that don't, and it's variable. That's a good example of that irregular rhythm. Treatment, if they're stable, is going to be some type of AV nodal blocker. Typically in the emergency department, we use cardizem or diltiazem. If they're unstable, then it's cardioversion. If it's multifocal atrial tachycardia, that's one that you can see 3 different morphologies to the P waves in a single lead. So you can see here the P waves are different morphologies. So that's going to basically be associated with a underlying pulmonary disease. So the treatment for multifocal atrial tachycardia is treatment of the underlying disease. The third group, wide complex regular, those are going to be your VTAC, your SVT with bundle branch block, or your antidromic WPW. So wide complex regular, your EKG is good at ruling in ventricular tachycardia, but it's not good at ruling it out. So you'll be looking for wide, regular, with AV dissociation, and sometimes you'll get these fusion capture beats, which this is a good example of that, where you actually end up getting a typical beat down through it, running from SA node down the AV node, and presents as a regular beat. That's pretty classic for ventricular tachycardia. So VTAC, in this picture you can kind of see it. It's running around. Just the ventricles have increased automaticity, and they're just firing at their own rates, not following the typical SA to AV node down the His-Purkinje system. Antidromic WPW, this is an important one to know because it changes your management. So this is where you'll get a beat that comes down from the AV node, but instead of firing down the His-Purkinje system, it fires down the accessory pathway first, and then comes backwards up the His-Purkinje system back into the AV node. So you get a circus movement running through the accessory pathway first, and then backwards. So you'll get a wide complex regular appearance to it. So again, fusion capture beats. Treatment, cardioversion, amiodarone. Those are the 2 major ones, especially for ventricular tachycardia. Procainamide is important because that's going to be your treatment for WPW with antidromic appearance. So you want to make sure that you don't give regular WPW. Like we talked about earlier, you can treat with adenosine. You don't want to treat a wide complex QRS with adenosine because it could be WPW in an antidromic appearance, and that can actually send them into ventricular tachycardia and death. So magnesium is good. You want to consider that for prolonged QTC leading to some sort of regular VTAC. Wide complex irregular, atrial fibrillation with a bundle branch block. You can have atrial flutter with a bundle branch block, or you can have atrial fibrillation with WPW. So irregular is, again, not a circus movement. It's caused by increased automaticity. wide, not following the normal pathway. So you get this wide, like, as an example here, you got AFib with WPW, so you got the atrium firing into the AV node, running it down and back up while it's still attempting to go down the normal pathway. So you end up with this irregular appearance to your EKG because of the fact that it's not firing the way it's supposed to. So you can see here delta waves. So not a very nice thing for someone to do, but it is there. So they'll have an irregular rhythm, wide complex, and it's concerning for WPW with AFib. Again, treatment, AFib, A-flutter, you treat it exactly like AFib, so you do some sort of an AV nodal blocker. If they have atrial fib with WPW, you can do cardioversion, or you can do procainamide. Either of those should be done in consultation with cardiology. Procainamide stabilizes that accessory pathway and then allows you to give an AV nodal blocker afterwards to slow them down. But again, all of that should be done in consult with cardiology. So we'll talk a little bit about the bradycardic dysrhythmias. Same steps: stable or unstable, wide or narrow. If it's wide, it's below the AV node, and if it's wide, it's not sensitive to atropine. So considerations: you want to think about drugs. Do they have some sort of calcium channel or beta blockade on board? Also want to be considering DIG toxicity. Is this an ischemic event, or do they have hyperkalemia? So again, bradycardic dysrhythmia, as you can see here, this is a wide complex QRS that's bradycardic. This would be concerning that they have hyperkalemia. Again, you start seeing the widening of the QRS, almost the sinusoidal appearance to the EKG. Again, hyperkalemia. You'll see some progression in hyperkalemia. So initially you'll see large peak T waves, and you'll start seeing some bradycardia, the widening of that QRS. You'll see the sine wave appearance, and then they go asystole. Treatment for hyperkalemia-induced bradycardia or symptomatic changes on the EKG would be calcium, followed by albuterol, glucose and insulin, bicarb, and they still say K-exolate. We don't use K-exolate much in the emergency department anymore because it was associated with bowel necrosis. But they do have another binding agent resin called Lokelma that nephrology really likes, so that's starting to be used more. But mainly it's calcium for membrane stabilization. Your albuterol, glucose and insulin, and bicarb all help shift the potassium intracellularly. And then your binding agents like Lokelma, and then your diuretics like Lasix to help excrete it. And then ultimately, if they're unstable, dialysis. Treatment: you can do transcutaneous pacing, you can do transvenous pacing, atropine to bombard the AV node, and it quits conducting. Sorry, I said that incorrectly there. Atropine, but if you do it too much, it'll quit conducting. Dopamine and epi. If you're concerned that there's DIG toxicity, or you get a DIG level that isn't within toxic, then you do digibind. There's two ways to do it. If it's a known dose overdose, you can calculate it out. If it's an unknown dose, then you give 10 vials. Calcium channel and beta blocker overdoses, this gets pretty complicated quickly, so you are going to be giving calcium channel, or for calcium channel blockers, you're going to be giving calcium 1 to 3 grams. For beta blockers, you'll be giving glucagon somewhere 1 to 5 milligrams. And then you're going to start with the aggressive therapies, the IV fluids, the IV pressors. Their pressor support may be significant, 2 or 3 times higher than the average comfortable level of giving people vasopressors. You can try atropine, but it's likely not to work if they're requiring that. And then high-dose insulin. when they say high dose insulin, they're saying 1 unit per kilo as a bolus. So for a 100 kilogram person, you give them a bolus of 100 units IV, followed by 100 units per hour. And typically you put them on a D5 drip and monitor their finger sticks while you're doing that. You can also do transcutaneous or transvenous pacing. From there, it can go on and you end up with lipid emulsion therapy. And then ultimately, if all of that fails in calcium channel and beta blocker overdoses, you can go to ECMO. So in summary, you want to assess your 5 steps to ultimately put your safety net on. Assess, are they stable or unstable? Look for P waves. Is this sinus or not? Are they wide or narrow? And are they regular or irregular? So wide, complex, regular, VTAC, VTAC, VTAC. It's VTAC until proven otherwise. So cardioversion, drugs typically don't work. Wide, complex, irregular, AFib with bundle branch, but treat it like WPW with AFib and you are okay. That's going to be cardioversion or procainamide. Your bradycardias, think drugs, ischemia, electrolytes. If you think these things, then you're going to be more likely to figure out what's going on with someone, and less people are going to die on you from the bradycardic rhythms. So your treatment is address hyperkalemia, address any overdoses, and then pace or give symptomatic or give drugs as necessary to treat symptoms. That is it. If you have any questions, feel free to reach out to Dr. Gardner or myself, and I hope that things went well.